Please speak. Yeah.
Yes, I am Dr. Bhola Ramshres, Chief Consultant Medical Journalist from Department of General Practice and Emergency. I have Dr. Kela Century. Hey, everybody. I'm also working in the Department of General Practice and Emergency of the hospital.
Okay, your voice is not very clear. Maybe this microphone you should keep.
A greeting from all sides, although some side maybe not working properly, but I'm anyway, still welcome you. And let's go ahead. Would you please introduce the first speaker, Dr. Udaya?
Dr. Shan, maybe I can introduce myself so that we can, I want to be respectful of your time. So
of
that
course,
we meet the time.
Please, of course, please go ahead. Thank you.
Okay. My name is Don Marchand. I'm a founder of a company by the name of Remote Medical Technologies. And can everyone see my slide right now with regard to what I'm going to speak briefly about? And I'm going to be as brief as I can to make sure that we stay on time. Can everyone see my slide?
Yeah, we can see you on this slide, no problem.
Wonderful. So today, what I have the privilege of being able to communicate or be able to talk to you about is something that our company has seen in the way of vision and also our contribution to the rural space. And it revolves around something that we talk about in the way of secure, high definition streaming of telepathology and radiology for remote locations. And what I'm going to briefly talk about over the next couple of minutes is I'm going to talk about a little bit about our core competencies in this space, namely what do we contribute to this space, what we're seeing, the value we provide. I'll play a couple of brief video demonstrations, or one video demonstration of what the technology is able to do. I'll briefly highlight some features, advantages, and benefits, and we'll talk about a customer testimonial that actually highlights the value that is actually brought to the rural space based upon the technology that we believe adds value, and also other customers have noticed add value within the medical space. With that said, remote medical technologies, what we do is when we get up in the morning, everything we do, we challenge the standard on how quickly medical facilities can provide more and better patient outcomes. And we truly believe that there's a more reliable way to improve and significantly benefit both patients, doctors, and the profitability models of these medical organizations. Many of you may know that many technologies in the rural space consider using a form or a workflow process based upon, I will call, store and forward, where maybe a snapshot is taken, sent to a doctor, and then that doctor might evaluate what is happening within or that snapshot about that patient. And it's all done in a way where everything takes time. In other words, it may take time to take the snapshot, send it to the doctor. The doctor may not take a look at it for a long period of time before actually making a call. We at Remote Medical Technologies are on the other side of the spectrum. We're in what we call the live, dynamic, real-time space, where we believe every second counts, where live dynamic video is being provided in a very secure way, and it's being provided to multiple doctors that want to collaborate together to make decisions in a very fast manner. So at the end of the day, we're talking about our organization seeing value in providing a way where doctors can save lives, where time is of the essence. And of course, we need to find a way by which medical facilities can also improve their profitability through the process. So we've done this by developing a technology that is purpose-built for this live dynamic streaming capability. Think of us as being able to connect to any medical device, whether it be for pathology, surgery, or radiology, and in a very secure way give the power to the clinicians to be able to all collaborate and instantly
Hello, Dr.
make
Morgan.
decisions.
Don Morgan, your voice is not audible to the venue. So can you check?
What we've done is we've purposely built technology that allows this live dynamic imaging to take place with any medical device, whether it be pathology, surgery, or radiology, such as teleradiology or telesurgery or telepathology. And we built a specific device to do this. It's very secure. We built it with security first. We also are able to drive live high-definition imaging through the whole process among multiple clinicians. We do it in real time, and we can do it among multiple clinicians at the same time. With that said, we have a number of different modalities by which we can show. And in fact, what I'm going to do is I'm going to stop sharing my slide presentation so that the other team members can actually play a video of our mobile cart technology, where whether it be to identify cancer or to be able to collaborate for educational purposes, or also maybe a fine needle aspiration. And this is one example for pathology. Is the team able to play this video? If I play this, it will probably come across very slowly, I believe. In this video, we've actually built technology where anything that is on this mobile wireless cart can be rolled into any operating room or into any facility and be able to transmit in a live dynamic fashion remotely to any clinician to their iPhone, iPad, Android device, PC, or Mac, so that multiple clinicians can make decisions in an immediate fashion. I will start my sharing again. This is just one example. We can do this for ultrasound. We can do this for grossing requirements. Okay, what's being played now is a second video with a customer testimonial. This happens to be University of Chicago. Can everyone hear the video?
No, sorry, we can't hear it.
Yeah, no, I can't hear the video either. So this happens to be a gentleman who actually is responsible for medical directions at University of Chicago Medical Center. And they're using our technology primarily for both pathology and grossing, where clinicians, no matter where they are within or outside the medical facility, can securely share live dynamic imaging of either pathology images off of the scope itself in a very secure, easy way with no security issues and no networking issues. And we're also showing here with regard to ultrasound capabilities. And we're doing it at the mobile level. So there we were actually showing on an Android device. But we are also able to do this on iPhones, iPads, PCs, and also any type of Mac-type Apple device.
Mr. Don, your time is only 1 minute.
Okay. So if there's something that I'd like to leave you with is we have organizations such as Memorial Sloan Kettering, University of Chicago, Johns Hopkins, Cleveland Clinic. All of these organizations and also smaller organizations that are looking to find a way to share images so that multiple clinicians can make a decision together. With that said, what we've built is a technology that is purpose-built, and we provide clinicians a way to have complete control on how they can easily make decisions on live, dynamic, real-time, gorgeous images, and do it the way they want to do it wherever they are. And I am very pleased and also privileged to be able to speak with you today. So thank you very much. I hope I've finished on time.
Jacob Carpio is from Institute of Philippine Culture, Ateneo de Manila University. Okay.
And to everyone, greetings from here in Auckland, New Zealand. So I am Jacob Carpio, a research assistant from the Ihatid LGU project. I am representing Dr. Dennis Batangan for this presentation. So the title of my presentation is Creating Digital Spaces for Citizens' Health Access, Data Governance for Informed Decision Making in the Philippines. So this presentation is a follow-up of at least 2 other presentations made here in APAN, in APAN43 e-health-based data and health services research for local health systems in the Philippines by Dr. Dennis Batangan, and during the most recent APAN45 meeting, the role of e-health in the implementation of universal healthcare coverage in the Philippines by Ms. Patria Garcia. Next slide, please. So I have only 2 main goals for this presentation: to present to you the Ihatid LGU project's experience on its attempts to encourage data governance on e-health. Later we will define what data governance is. And also we would like to showcase existing success stories from our partners at the local level, as well as challenges that they face towards achieving improved health adoption, e-health adoption in the rural healthcare setup within the country. Next slide, please. So just a bit of background on how rural healthcare is in the Philippines. So the provision of basic healthcare services in the Philippines has been devolved to local government units, cities, municipalities, and provinces nationwide, except for the autonomous region in Muslim Mindanao. As you can see by at the figure on the right side of the screen, there are at least around 2,500 rural health units and around 20,241 village health stations in the country as of late 2017. And all of those are being encouraged to adopt e-health technologies, starting with telemedicine devices and electronic medical record systems. So in essence, the quality of local healthcare is a function of the support of the local chief executive, and some support received also by the rural healthcare units from the national government. Next slide, please. As in Ihatid, in its current version, Ihatid LGU is contributing to the National eHealth Program agenda by providing government-validated EMR system to rural health units nationwide. Eventually, we hope to connect with other electronic medical record systems and able to contribute to the Philippine Health Information Exchange, which is an ongoing initiative in the Philippines. Next slide, please. So just a quick preview of the technology. So Ihatid LGU is mainly an Android-based electronic medical record system with a partner web application for user management and reporting. Now, some of the main features of the application includes an offline mode usage, so that those without internet connection can use the technology, some visualization of the aggregated health data, reports generation, some notifications for some notifiable diseases which a rural health unit might want to watch out for. And the technology uses a centralized management of data. The data is online data is stored through the government cloud of the Department of Information and Communications Technology of the Philippines. Next slide, please. So in essence, besides the EMR system, Ihatid LGU is now diversifying in order to develop other technologies and activities to support informed and improved decision-making on the rural level with regards to health. So we are anticipating to be able to connect with other EMRs, be standards compliant, for example, for HL7, collect data for other health-related reports that are not necessarily collected on the rural health level. And we're also undergoing undergoing technology assessment for commercialization, so that to ensure that the technology that we provide to our rural health units will be sustained for a longer period of time, even outside the duration of the project. Next slide, please. Now, besides the electronic medical record system, we are also in partnership with other projects, such as the Learning Interaction and e-health technologies in ASEAN, in which we partner with several ASEAN countries for knowledge exchange for their practices on the rural health level. Next slide, please. We are also developing with the European Union Erasmus Plus project, the competency project, which aims to develop massive open online courses, or MOOCs, for Filipino rural health workers on topics such as data governance and health. Later we'll get into that. Next slide, please. Also, this is a new project, an attached project of the EHATID LGU, or Ituro. Turo in Filipino means to teach. So Ituro aims to create an online database and referral system on the available e-health and related healthcare service training available to more Filipinos based on the demands of the Philippine healthcare industry. So basically, these attached projects of the EHATID LGU aim to capacitate our rural health workers towards better use of e-health, and especially the electronic medical record systems. So at this point, I'd like to define what data governance is, at least from the side of the project. So data governance can be defined as structuring of e-health information, health information systems, such that the yielded health data is not only of good quality, but also offers additional insights into the operations of health systems that are typically not available through conventional and often paper-based data collection methods. Next slide, please. So in here, we would like to highlight some of the good best practices that we've found in some of our local health partners. This is a local government health scorecard implemented in one of the provinces in the Philippines. So basically what they do is they collect data from health data, aggregated health data from the rural health level using specific indicators. They make a visualization out of it, and based on the scores, based on the improvements of the different rural health units and municipalities and cities within the province, they usually hold some provincial health summits where they give awards to the best performing cities and municipalities when it comes to public health improvement. Next slide, please. That course on data governance, which is being implemented by the province, is now available as an online course. So we have developed it together with the University of the Philippines, Diliman, and with the assistance of the Department of Health. So anyone with access to the internet can take the lesson for free. Next slide, please. So some of the challenges that we have observed together with our partners, number one is the lack of support in transition from paper-based to paperless systems. So it has been a hard time for some of our local government partners to adopt electronic medical records for a host of valid reasons. Some of them would resort to backlog encoding just so backlog encoding means that they would still use paper-based systems and then transfer that eventually to the EMR, doubling their effort in recording the patient records. And of course, some changes in how they would validate their health data from the local level up until it has been reported to the national level. Also, there's still a huge gap between the distribution of the electronic medical records in the Philippines. Some unpublished report would tell us that we're still halfway to go in terms of reaching all of the rural health units and the village health stations in the country. And some also, a valid concern would be the lack of appreciation for e-health interventions, maybe perhaps due to its the inconveniences that it costs some of our users. Next slide, please. So basically, us in EHATID, with the efforts that we're doing, the implementation of the electronic medical records and other capacity building exercises, we want to contribute to efforts in creating what they call a social innovation in health, where the community is very much involved in order to develop stronger health systems and programs. In the Philippines, we have recently recognized some social innovations and health initiatives, including some telemedicine activities from the University of the Philippines, Manila. Next slide, please. And I would end my presentation with that. Thank you very much for your attention.
Send applause for Mr. Carpio. And then the next presenter will be introduced by Mr. T, Professor T.
Yeah, I just like to know.
Is ready, but we are trying to share the screen.
Okay.
Yes, we can see it. Please go ahead.
I'm Dr.
You can go
Rajkumar
on.
here. About how we are trying to develop a resilient rural healthcare system to the remote mountains of Nepal. Next slide, please. This is the place we are staying and we are working from. This is a Nangi village at altitude of 2,300 meter height. This place, of course, everybody can appreciate, looks very beautiful, isn't it? But living a life or delivering any sort of services is not as beautiful because of the geographical constraints and so many constraints related to the geography and communication and transportation. Next slide, please. So this is the another picture to other face of the same picture from previous one, which shows the landscape of the area where we are dealing with, the traditional way of houses. That is small green one, that building is our health center, hospital, and nearby there is a tower, telecommunication tower, upon which we rely on for the distant telecommunications. Next slide, please. Here, I want to show that the area contains high hills and mountains, and small cluster of villages are scattered in the different terrains of mountains. There up in the right side, you can see some clumps of the houses, but most of the villages are not like that. They are scattered in the different plains of the mountains. And these territories are centerless territories, remote from the administrative and economic hubs. Next slide, please. This slide picture a bit from far away from the same place, Nangi village, where we are staying. The houses and villages are sparsely populated, few hundreds to 1,000 population in 3 to 4 hours or maybe 6 to 8 hours walk. Next slide, please. And the roads and the paths are serpentine, they are muddy, scary, narrow, and the transportation is really difficult to the place and from the place. Next slide, please. Most of the time we rely on the small four-wheel jeeps like that, and the transportation and ride is not only risky, it's hectic and lengthy, and you can imagine how, if anybody falls ill or has some problems, how we can transport the patients to and fro from the places. Next slide, please. Apart from these difficulties, we have some exciting thing about the place also. The communities, those people are running their own different sort of services, like community laws, handicrafts, handmade papers. They are producing their local jam and wine out of the peach and other fruits, running community meeting hall, auditoriums where they can hold their cultural programs and some sort of activities. Next. Here I would like to show you two pioneer people, along with Mahabir Poon and Dr. Soros Dital sir, along with Public Health Concern Trust. Our project has translated into the reality. Public Health Concern Trust is a non-profit NGO-based organization which is running the Kathmandu Model Hospital, from where we are broadcasting, and it also runs some other academic and community health-oriented programs. Next, please. This slide is to show the information and telecommunication connection in the place where we are working. In the center, there is Nangi village. You can, I hope you can see that. And the Nangi is interconnected with the territories and the villages. And we rely on that ICT connections for our health service delivery. Next. We can maybe many people then can question or can think that why we are choosing these distant territories for the healthcare services, because they are visibly inaccessible, of course, and they have their own unique realities and constraints for the delivery of health services, and the government and the related bodies didn't have specific activities, health activities tailored to the status and the geography of the place. Next. But though they have long been outshadowed in the political unstable circumstances, internal conflicts, or the centralized government system, but with the advent of the new federal system of governments, we have got new ray of hope, because the local governments, they have become more stronger. We hope we can cooperate with the local government bodies as well. Next. The healthcare system model for our rural healthcare is that there is a local hub where we are working or residing, and they are connected with the village units as shown there by ICT, and we will be staying in constant touch with these village units, and we'll be advising or monitoring the healthcare services. Next. 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 So you can observe there. And here, this is the small healthcare center, hospital, where we are working. We have small team of healthcare workers, 2 doctors and 4 paramedics and 2 helpers. Many people maybe they will not call it a hospital. Of course, it's not a big hospital, but here we can deliver primary healthcare services, and after adding or expanding some services, we can deliver secondary level of hospital so healthcare services to the local population. Next. Model, our healthcare model basically has 5 building blocks. First one is village units, as I was talking about. These are installed in the cluster of villages in the periphery, and they have resident grassroots level healthcare workers, and they are interconnected and to each other and connected to our hub. Second one is the mobile medical team. I think this one is a new concept, different from our conventional healthcare system. And our new paradigm is not waiting for the patient, but we are reaching out to the patient, to the people. Next. Third one is the rural hub, where I just show you the picture. It is headed by the general practitioners like me, along with the another two doctors and few paramedics and nurses, where we can perform the common medical and surgical life-threatening interventions. And when patients are needed to refer to higher center, we will refer from the rural hub. Fourth one is the connectivity, with the best and great efforts from Dr. Mahabir Poon. We have got the connectivity facility in the territory, and the connectivity also helps us for CMEs, data sharing, and referrals of the patient to other centers. Next. Another important aspect of our healthcare model is the community participation. We motivate and the community for their voluntary participations, and these are ensured through by their continuous training and demystification of our medical knowledge, training them about the primary health care and the healthy lifestyles. And these are supported by the community managed micro insurance. I think that can make them self-reliable and sustainable. Next. And the project operates in the mobile unit moves from one place to the other place in the territories, and they collect the data, the vulnerable group of people, their health status, children, elderly, or people having chronic disabling diseases, and their healthcare needs. Then in the same way we can design the healthcare activities. Next. Here I would like to show you some of these slides, some of the pictures of these services we are trying to deliver. We are delivering in the first picture the emergency services, making use of best out of these oxygen concentrator, some minor surgeries, ultrasounds, and OPDs, and lab facilities. Next. Often we hold medical and surgical camps every 3-4 months and vaccinations along with the help of the government. And the nearby school children, they get their health checked up every month. Next. And we are trying to build up a cooperation with the local government people, local social activists and teachers and so on. Next. Here I would like to show some of the, in the first slide, we would like to embrace the newer technologies which can help for the delivery of the healthcare services. First slide you can see Mahabir Poon, he is testing his medical drone. And next slide, here I would like to show you, we are, okay please next. We are holding the telemedicine conferences or live broadcasts of the classes from distant Kathmandu Model Hospital or maybe even from other parts of the world. Next. I would like to, in conclusion, I'd like to say that though we are trying to do higher accomplishments, but still we have to realize our reality, the reality of the healthcare needs of the underserved population. Next. And here is my little son. The way he awaits me, I believe many of the children, their parents, grandparents, and forthcoming generations, they are awaiting our best efforts for the delivery of the healthcare services to the remote population of the Nepal. Next. And my sincere gratitude and heartfelt thanks to Professor Shimizu from Japan, Professor Han from Korea, Professor Chiang Thi Chuang from Taiwan, and of course to Professor Dr. Dital and FEC team, Mahabir Poon, and my hospital staffs. Thank you.
Thank you very much. Okay, so we will keep on going for the next speaker, and we will leave all the discussion at the end of this.
Yes, Professor. The next speaker will be Mahabir Poon, who is very much renowned in this remote networking system. He was awarded Magsaysay Award from the Philippines for community leadership in 2007. So here he was undergone cataract surgery recently. Even then he came here to present this presentation. So here is Mahabir Poon.
Hello everybody, thank you for this time. First let me see the slides from there. So Dr. Rajkumar, he already mentioned everything about this resilience health program model we have started in the mountain with the help of public health concentrates and Kathmandu model hospitals and the doctors from there. So I don't have to explain anything more in that area. What I would like to explain today is a technology that we are adding in that programs to provide some services for the rural healthcare, and that is about drone technology that we are developing to deliver medicines between those hospitals and the clinics. So I am Mahabir Poon. I am the chairman of National Innovation Center. This is not for profit organizations we have established, and we are doing different types of innovative activities using these talented and innovative people of Nepal. The goal is to keep them here in Nepal. So okay, next slide please. This program, Resilient Healthcare Model, Dr. Rajkumar, he already explained it. So next slide please. And also structure, he already explained about how it will work. And the next slide please. So just to give some clear idea about what that healthcare model is. I have these slides. In the middle there will be a hub, which is Nangi, And around Nangi there are about 10 health posts. Some of them are government health posts, and some of them are private health. Some of them are private health posts, health clinics, and those that hub or the hospital in Nangi will provide services to the other satellite clinics. For connecting those clinics with wireless technology for communication, that's what my main role is. And we have started doing this since 2004. And still we are doing it, and we are connecting more and more hospitals and clinics. Next slide, please. And we are connecting that through wireless, because we don't have fiber network here in the mountain. It's very difficult to put fiber, so we have to rely on wireless technology to connect all those hospitals and clinics. Next slide. So let me just go through this drone technology we are developing. All of you know that there is already drone services. People are providing in different parts of the country, of the world. They are doing it in America. They are doing it in Africa, and there are drone already available in the market. But the reason we are developing this drone is because first, those drones that is available in the market are very expensive. We are not going to afford those drones available in the market. The second goal is to use the innovative and talented people, engineers of Nepal, to develop the drone by themselves here in Nepal, so that it can be cheaper, and it can be more economically feasible. So that's what we are doing. And next slide. And the second drone is, this is a fixed wing medical drone we are developing. The earlier one was multi-copter. Next slide. And this is a hybrid drone we are going to develop. And the next slide. So let me explain a little bit about these three types of drone we are developing. The first one is multi-copter. It will have 6 rotor blade, or maybe 8 rotor blade, or 4 rotor blade, depending on the need. So the reason we are developing this multi-copter is because they are good for short range. They can take off like a helicopter and land, and but they are good for only for short range, maybe 5 kilometer or 6 kilometer, within that range. But if we have to deliver medicines in the remote more further distance areas, we have to rely on fixed wing drones. That's why we are developing the fixed wing drone also. This fixed wing drone will go 25 kilometer, 20 kilometer, or 30 kilometer, in that range. That's what we are developing now. And the third one is hybrid, which is a combination of fixed wing and multi-copter drone. The reason we are developing this hybrid drone is because depending on the situation, sometimes the drone have to go there and deliver medicine and collect body fluid sample from the rural clinics. The fixed wing one just can go and deliver medicine and come back by itself, but it cannot just land. But the hybrid one, the goal is to use the hybrid drone to also land in the rural clinics and collect the body sample, like the blood sample or urine sample or stool sample, and bring back to the hub for lab testing. Next. So this is how we will use the drone. First, all this the clinics, satellite clinics, will be connected to the hub or the hospitals through wireless network for telemedicines or for communications. Also, then when there is some problems, when the clinics in the remote areas, they need medicines, they will call to the hub, and the hub will send medicine through the drones to that specific clinic in the village. And then if there is need to collect like the body fluid, body sample, they will also, the village health force will also ask the hub to send drone, the hybrid drone, so that it can land there and then collect this body fluid and to the hub. And there will be lab. They will test the body fluid and then deliver the necessary medicine. This is how it will work. This is going to be interesting project. The reason we are doing it is because like Dr. Rajkumar, he showed the geographical situation of the remote areas of Nepal. It takes maybe, if we walk from one village to another village, it takes maybe about 4 hours, or within this, even within this Nangi, hospitals, some of the clinics are, 3-4 hours walk. Some of the clinics are 1 day walk far. That's why whenever there is need, we will use the drone to deliver medicine, and using the the drone, it will take just maybe half an hour. So that will be very helpful whenever there is a need of medicine in remote areas, because the medicine is always not available in the remote clinics. They have to go to the cities and bring the medicine. That is why we are using this drone. Thank you very much. Next slide. And there is my name and my contact number and my email. If you are interested in this project, you can help me. I mostly can help building the network, wireless network for communication, and also I can we can build the drones for medical delivery. Maybe in future, if you need this kind of support from Nepal, we can help you. Thank you very much.
Thank you, Mr. Mahabir Pon. It's a very interesting presentation. Despite we have a burning question about your presentation, we still need to proceed to the next presenter. Is
yes.
Mr. Binod
Yes,
Dangal. Mr. Binod Dangal, is that you?
Yes, Ari. Can you hear me?
Yes, we can hear you clear.
Yeah. So next presentation will be from Charikot Hospital. Dr. Duncan Maru. He is a Chief Executive Officer of Possible Health, and he is an epidemiologist and physician from United States, and he is working on high quality, affordable rural healthcare system in Nepal. So he will be presenting. Dr. Duncan, please.
Okay, namaste. Thank you so much. This is an amazing group of people, and it's really an honor to join you all. I've had as mentioned, I'm an internal medicine and pediatric physician as well as an epidemiologist. I am at the Arnhold Institute of Global Health at Mount Sinai School of Medicine, and for the last 11 years have had the distinct privilege of working with United Health Nepal in both Acham and now in Dholaka. I'm going to go through some of these slides pretty quickly in the interest of time, and then hopefully we can have some discussion, and certainly if anyone is interested in follow-up. And we were sort of pulled this together at the last minute. I just reached Dolika a bit early, so I was able to join everyone and present with Dr. Dengal. So you can go to the next slide. Yeah, you can go to the next slide. Go next slide. So So I think I sort of back when I was doing my MD and PhD studies in the United States, I became very interested in rural. Back right at the end of the civil conflict, I had the opportunity to come to Acham. The meaning of the term Acham is Acha Am, and in many ways that's been Acham has been a very Acha Am in my own personal and professional life, learning about the challenges and opportunities present in rural healthcare systems. And this group already knows the deep challenges that rural populations face. So we'll go to the next slide. I personally, again, as an American, as a foreigner coming to Nepal, I've had the opportunity to really learn from the Nepali system and try to understand what the strengths are and what I, as an American physician and epidemiologist, can learn from. And today, at this moment in Nepal, it's again, as an outsider looking in, it's a very exciting moment. Unlike in the United States, there in fact is a constitutional right to health embedded in the Constitution of Nepal. Recently, we've also seen the formalization and initial successes. I know all of my Nepali colleagues say that the national insurance coverage scheme, which is a pillar of universal health coverage, it has been slow, and many people are skeptical of its success. But I will say that in my study of it and over the last few years, in my participation with the committee that runs the social health insurance scheme, I feel very good about it, and I think it will be a model for other countries as they go along the path of universal health coverage. In parallel with this development of the federal financing of healthcare, there has been a realization of the idea of local self-governance, which has its roots over the last few decades of various people's movements in Nepal and the 1999 Local Self-Governance Act, and most recently these remarkable elections that elected approximately 750 mayors and deputy mayors around the country, and has really paved the way in the health sector for local governance over public sector care delivery. And that is a tremendous opportunity for organizations like ours, which works on a public-private partnership approach. So next slide. Again, I think that folks in, next slide, please. I think, again, folks in this audience are very familiar with Sustainable Development Goals, but just to emphasize that that over the last over the last 2 decades, we've made tremendous progress in this notion of improved access, where institutions from the health post and sub-health post, the primary health center, have in fact increased vaccination rates and antenatal care coverage and coverage of childhood illnesses and institutional birth coverage. But at the same time, there continues to be a large quality gap, as well as an increasing amount of out-of-pocket expenditures at the point of care by patients. broadly in South Asia, we see about 70 to 80% of the entire healthcare economy is out-of-pocket expenditures by patients. In Nepal, it's a little lower. It's closer to around 55%. The government of Nepal, as part of the Sustainable Development Goals initiative, is committed to reducing that to 35% by 2030, which is an enormous uphill battle and requires folks, all of us working together to figure out how to reduce financial burdens to patients. Again, given the predominant economic model in both the public-private sectors before insurance has been point-of-care user fees. Next slide. Again, the possible and United Health Nepal's mission is to improve healthcare for underserved populations. Next slide. We really, again, this is similar to a number of the other presentations. We really are interested in integrating healthcare from the different tiers. We know that rural people need to get care in the home. They need to get care at a peripheral facility, and they need to get care at a more centralized facility, and ultimately a super specialized facility. And as again some of the other presenters talked about, how do you reach these patients that live in very remote places, and how do you kind of flip the healthcare system from waiting for the patients to proactively going into their homes and working with them. And then finally, we have a strong interest in data as a basis and foundation for health systems learning. We'll go to the next slide. And actually, we'll skip this slide and just keep going, just in the interest of time. Next slide, please. And next slide. We'll keep going. Next slide. I've talked about that. Again, we work in 2 different provinces in the new provincial federal structure of Nepal. Again, similar to many other places that folks have mentioned in previous conversations. I will say again, as a foreigner working here over the last 12 years, one of the very remarkable aspects that I think foreigners especially need to bear in mind is that rural places are, just like other places of human societies, are highly dynamic. And I've seen tremendous amount of development in Assam, for example, over the last decade. Where you now have pitched roads, where the distance to get to the hospital from Kathmandu has shrunk, where you now have Wi-Fi and multiple mobile service providers, and where urban centers are increasingly having middle-class populations. At the same time, I would say that for many rural people outside of these urban centers, and who still need to walk quite several hours perhaps to get to the pitched road, their lives may have not changed as much over that period of time, and they still suffer from various forms of economic and social and geographic marginalization. But I think it is very important for us coming from outside to not sort of essentialize poverty and essentialize rural places and act as if they're sort of always going to be poor. Both Assam and Dolakha are rich in natural and human resources, and will continue to grow and develop over the coming decades. And then the question for us in rural healthcare is how do we support making it more equitable? One key aspect has been, for our work, has been developing a community health worker model. The government of Nepal has had a long-standing female community health volunteer model. I, as an American, will say this has been something that the USAID, the development arm of the U.S. government, has invested heavily, contributed, and supported over the years. I would also say that the female community health volunteer model needs to be upgraded, and so we are currently working on we're doing a national pilot study with the government in Acham and Dolakha around the next generation of community health workers. Again, as an American who somewhat takes responsibility for our mistakes, I would challenge anyone to say that if there were 50,000 strong volunteer men in the healthcare workforce, there's no way they would be still volunteers. And so I think that there is a strong gender lens to this question of professionalizing community health workers. People deserve to have a livelihood, and healthcare workers should be paid. And we have a mountain of evidence to suggest that professionalized community health workers are effective and can reach places. And at the same time, we need to build off of the female community health volunteer model that the government has pioneered and utilize its strengths. So next slide. So I'm not going to get into the details, but the team with a number of colleagues has built what was called now Nepal EHR, which has community health as well as pharmacy, surgical, inpatient, outpatient, and supply chain modules, and as well as integration into the government's DHIS2 reporting system. We are implementing that in the two government hospitals that we work in, as well as a third hospital in Nuwakot. That was our first test of implementing Nepal EHR in a government-managed facility rather than one managed on a public-private partnership. Next slide. Again, we could talk about this slide for an hour or more, but just to say that the key question that we constantly have to ask ourselves are, what are the frontline healthcare workers? How do they use data? How do they know whether they're improving? How do they know the gaps? And that includes both a health assistant or a community medical assistant. That includes a physician. That includes also municipal administrators up into the Secretary of Health in terms of how do we use data to know where we should make sure we have C-section capacity, where is the next outbreak occurring, where are chronic diseases not properly treated. All of these questions require data, and the backbone of getting that data should be entered by healthcare workers efficiently at the point of care and used for their own purposes. Next slide. And then in the interest of time, I'll stop here. But we are, again, I just want to, as far as how we operate, we have sort of two main government hospital hubs in Acham and in Dolakha, and then we are currently developing with the municipal governments in Acham a municipal care model where we implement community health workers, the Nepal EHR, and longitudinal care protocols. together with the municipal government, based on local self-governance principles, again enshrined in Nepali law, and as well as utilizing national health insurance as the cornerstone of federal financing of universal health coverage. Where I primarily in Mount Sinai School of Medicine and the Arnold Global Institute play a role is in supporting efforts to translate work in rural, the work of Possible Nyaya Health Nepal into government policy, and also to share our lessons with the broader world. Aspects, again, of how do community health workers do surveillance of pregnancy and childhood illnesses, how do we implement effective EHR systems, how do we develop mental health and chronic disease protocols. These are issues that are facing rural health systems all over the world, and I think that Nepal has tremendous amount of strengths in its governance and its culture and its people to support and share lessons of innovation in rural health systems around the world. So I will stop there, and I'm happy to discuss more with you all on this call and in other venues. Thank you.
So that's all our presentation, and so shall we start the question answer? Does anybody would like to any question from the floor?
I have one question with Mr. Don.
Yeah,
I'm
please.
Dr. Uday Koirala from Kathmandu Model Hospital. So we at Kathmandu see your technology. We love it. It's fascinating. But how affordable it will be to deliver that system in actual rural healthcare system?
Are you asking Don Marchand? You can hear me now?
Yeah, here from Benvenue, APAN Benvenue, we can hear you. John, please go.
Okay. Maybe I don't know if he can hear me. It's a very good question, and I think what I do understand that each region needs to be treated differently with regard to the cost model. And I'd be happy to look into more detail what type of cost model would apply to your region and find a way by which we might be able to indeed implement that kind of technology. Now, we need to also consider other important aspects of how the technology can be delivered, such as video bandwidth and also just general upload and download speeds. So to answer the question, we have some flexibility with regard to how the technology can operate and how it can operate effectively. But I would be more than happy to research how, within your region, something could be worked on. And I'd be happy to evaluate that in more detail.
Okay, nice. Thank you. Any more questions? Is that clear from the people who raised the question? Sorry, maybe they...
It's a very interesting presentation about the e-HATIT. But can you explain about your challenge about transition from paper-based to paperless? Because we know that usually we use the medical record. It must have like a wet signature, and it has to be accommodated into the paperless. So how you manage that problem?
Thank you for your question, sir. At least in our experience, what we have observed from our rural health units which are implementing is that even though they have implemented medical record, electronic medical records, even before we have implemented ours in their system, they would still primarily use their paper-based system. So the electronic medical records that they're using, even I think even for some other EMRs available in the Philippines, it is not well integrated into the clinic workflow. So instead of them being able to use the technology from the entry of the patient up until the dispensing of the medicines and other activities within the clinic, they just put it later on during the day. They do with the normal activity, and then they will encode in the electronic medical record afterwards, which is essentially additional work for them, or it requires additional workforce, hiring of encoders, which takes away some cost from the rural health unit. So it's been a challenge, and we've seen some of in our sites, huge collection of paper-based systems being implemented alongside electronic medical record systems, which adds to the burden of the rural healthcare workers.
Okay, so this project then must also accommodate an extra cost for the encoders after the all the health services conducted. So they encode the paper base into the paperless after daily activity is over. Is that like that?
In some cases that happens, and usually it's the local government unit who covers for it. But we're trying to make, at least in our system, we're trying to make it so that it's intuitive, so anyone who has a basic background of an Android tablet will be able to use it. So eventually we're hoping to encourage them to incorporate the system into their clinic workflow.
But the utilization is like how big the percentage of utilization in total primary or remote healthcare? Is it 100% already utilized?
Not 100%, I would say. The project was started implementation in 2015. There were some success stories, but I would say that the implementation is still very low. Not just because of the difficulty in adopting the technology, but also with some policies being implemented within the Philippines itself, which on the level of the rural health unit, it gives them a bit more hard time in adopting fully an electronic health record system.
Thank you. Is there another questions? Remote. I also have a burning question for Mr. Mahabir Pun, but okay, we don't have any questions. So, okay, as my background I also from the public health department, community health. So it is a very interesting presentation with Medicopter technology. Mr. Mahabir Pun, are you still there? The drone. The drone is just how many village health posts are already utilizing this drone, and how, as my understanding, the utilization is for sending the medications, and is it already involved, or is it already covered by the government, or yeah, how to cover the cost of the utilization of this drone? Unfortunately, yeah, now we can.
Yes.
Okay.
Okay. This,
So,
this road project is not, done by the government. We are not getting any support from the government nor any organization. This is the, National Innovation Center doing it. Right now, we are just, building it and testing it. We started it, about 8 months ago. And our engineers are working for the last 8 months to build it and test it in different environments. So it is not quite done yet. The goal is to make it fully autonomous so that it can go and deliver the medicines and come back by itself. So the engineers are right now, the engineers are working for developing, especially mostly the software to make it fully autonomous, and it is not fully implemented in the real village, but we have tested it in the rural environment. So we hope it will be complete. I mean the first implementation will be within next 4 months.
Yeah, can you give us illustration about how many health posts or village health posts is already using this, and how often is the transportation or the sending process using this drone? Just give me the illustration.
Like I said, we have not implemented in the real village. We have tested it in different environments because we have to test the hardware, we have to test the software, everything. So we are testing it. So we are hoping to implement it within next 4 months.
Okay, I'm sorry.
But it will work. We are very hopeful that it will work.
Oh yeah, we also have a question from the venue, please, Mr. Satya.
Yeah, this is Satya from India. These drones are only produced for this healthcare needs, or commercially also available?
So these drones are, at this moment, these drones are being produced for the healthcare only because we have named it in a medical drone or medicopter. That's the name. But once we develop this drone, then and when it will start working, well, then we can produce it on commercial scale, and it can be used for many other purposes. We have a very big team of engineers who are working it, and they are trying to make it, make the drones as useful as possible for the rural people and for the communities. So it can be used for any purpose, any other purposes.
Okay. In India, generally, in my country, we need to have security clearances for using a drone for any purpose, any area. Is that same in your country also, being a border country?
It is as strict as it is in your country, in Nepal as well. So we have to get clearance from the government, and we will get it from the government, the clearance from the government.
So when one patient directly utilizes these services, is there be any additional cost to the patient on this?
Look, the purpose is to provide services to the people in a very remote areas or people to unreached people. So we cannot charge high fee for providing these services. Actually, this is the local government. The local governments will be implemented. We will have to sign MOU with the local governments and let the governments use it in their area. So the local government will of course pay for some operational cost, and we are providing technical service only to them. It is the local governments who will implement this service and pay for it. And the users, especially the people who need medicine, they will have to pay, I think, very little fee for getting that service, because these are mainly targeted for very poor people, and the poor people cannot afford to pay high fee for this kind of service.
Okay, thank you so much.
Okay, one last question: how long is the distance, the maximum distance that you plan to be covered by the 5 kilometers, if I'm not mistaken?
30 kilometers, because with the multi 30 kilometers.
30 kilometers. Okay.
Yeah.
So yeah.
So depending on the distance, we have to use different kind of drone. For the short distance, we can use maybe hexacopter or quadcopter or octocopter. This multi rotor drone for short distance, like 4-5 kilometers. If the distance is 4-5 kilometers from the hub, then we will use this multi-copter drone. If the distance is say beyond like 5, 10, 15 kilometer or 30 kilometer, then we will have to use fixed wing drone. And if we have to collect the body sample from the villages, will have to use hybrid drones, because hybrid drones can land as helicopter and take off as helicopter. The big
Okay.
drone, it will just go and deliver the medicine and will come back. It will not land in the
Okay, thank you, Mr. Poon. It's very interesting, and we look forward to have the result of your project.
Yeah.
But please be careful regarding this is a biological things that you carry. In fact, your drone is having an accident. You have to be careful.
I think thank you. It's a wonderful opportunity to share our work, and I would like to thank Dr. Duncan here. And like yesterday, he came and I actually asked him to do the presentation. That was very nice, and it's very nice to know the technologies that people are developing and all aspects of new models of healthcare in the country, and the progress of telemedicine, which is really making a good progress. And we would like to thank you so much. And a few words from Duncan.
Thank you all. I think it's an amazing forum for collaboration. I think we all can appreciate how disconnected and isolating rural healthcare can be, and to have a global community like this is really something special. And so thank you all for taking the time, and look forward to further collaborations and idea sharing.
Thank you so much.
I can see doctors from Untitled Hospital. Can you please say something?
My neighbors.
Hello.
Yes.
It was good to participate in this program. It was good to know about different services going on in rural health in Nepal itself and beyond. We'd like to congratulate all the presenters for presenting such wonderful presentations. Thank you.
Yes, thank you. And so we also would like to thank all the engineers who worked hard to make it successful. Mr. Mohan from the venue, I think, Mr. Nirajan, Pramod, Sushil, Dr. Dennis, Dr. Radhika, Mr. Tilak, Mr. Darwin, Mr. Don Narayan, all who helped in this technical aspect, and also Neeraj and Rosen from Kyushu University. Thank you very much. So I don't see Dr. Dennis. Is he here?
He was online, but now he's dropped. So maybe he's yeah.
So is there anyone left to?
Yeah, he was, but now he's not on the line. So maybe he's.
So closing remark from Mr. Don.
I just wanted to thank you all very much. It was a wonderful time presenting to you guys, and I learned a lot through this from the other presenters as well. Again, thank you so very much for giving me this opportunity, and I look forward to staying in touch with you and learning also more of some of the requirements from a cost perspective on proper deployment of telemedicine worldwide.
Thank you very much.
And of course, thank you, Dr. Adria and Professor Chang for helping from venue. Thank you very much.
Thank you for this nice arrangement. Okay, so the session is closed.